Okay, number one allows us to put the patient in a semi-sitting position, okay, which is where we do many shoulder surgeries, whether it's arthroscopic or open. We're in that semi-sitting position. It's also called the beach chair position. Okay, the second reason for it is, as we started to do shoulder arthroscopy, we had to get to the back of the shoulder. Okay, and so what we used to do in the old days, we never had these things. We would take a regular bed, okay, we'd put them in the, what they call the lithotomy position. The kind of, we can make the back go up and everything. But the problem was, we'd have to take the patient and move them all the way to the side of the bed, and we couldn't support it. Okay, so then we decided, then they designed these kinds of things so that we could put the patient in a sitting position and then clear the back of the shoulder. Okay, that's why this piece here slides. Okay, when you position this on the bed, this part here slides. Okay, and actually this should go further out. I think we should do that, right? So this is the one that goes on there. This is, okay, there's another clamp that goes on here, and this should be actually further out over here.
These go down.
No, these go down, yeah.
Oh, those go down,
Yes.
okay. Because they'll be in the way. What happens here is that we can actually slide, and I want to screw this up here, and it's tough to do, but this thing slides. See how it slides? Okay? So, for a big person, okay, male or female, this goes in the center. For a smaller person, you need to move it to the opposite side. And again, the reason is that we want that shoulder exposed. Okay, the other reason why you would move it to the operative side is, remember we used the spider arm holder, okay? And if the patient is way over here, the spider arm holder is out here, then we can't get that shoulder adducted, and we can't rotate it and put it in all the different positions. So, get some idea of what the patient's size is before we put them on the bed, because it is impossible to slide this thing once it's on the bed. Okay? So you can see how that slides. And you want to do that before you put that on, because now that's heavy. Did someone press on the pedal? Oh, okay. It has no.
Okay, as soon as we...
Okay, so this device right here is called the tenant beach chair. This right here is called the spider arm holder. I know you guys always refer to the whole thing as the spider. It's not, okay? This is the tenant beach chair, it says it on it, and this is the spider arm holder, okay? And we haven't always used them together. So, now we know why we're using this thing, okay? Put the patient in a semi-sitting position and adequately pad and support them so that they don't move during the case. So yesterday down at Summit, I'm doing a case, and it's a big kid, and I'm fixing a labral tear on him, and I'm scraping off the bone on the front of the glenoid, okay? And I'm going, why is this guy moving? Okay? And what had happened was that the ladies had put these in backwards, okay? So these are your kidney rests. So we've got a big guy, I mean, bigger than anybody here, I mean, big husky boy, and we're not supporting his chest because they put these in upside down. Okay? So for a smaller person, okay, we have some little ladies with short torsos. If we put these in the right way, this will be jamming in their axilla, which is not a good thing. So we will sometimes put these in upside down. Okay? So now we know how to get this onto the operative table. We know how to position it right to left. Most of the time it's going to be center. Small person, move it to the operative side. Okay? Do it before you put the spider arm holder on, because this is just a lot more weight. So let's talk about the spider arm holder. If I'm doing an arthroscopy, most of the time we'll have it centered, okay, and straight. Okay? If I'm going to use the C-arm, it's the same thing. we'll have it centered and straight, because if we tilt it up, we won't be able to get the C-arm in. If we're doing something else where we're not using the C-arm, like a total joint, sometimes what I'll do is I'll move it to the non-operative side and we'll tilt it. Do we have power on this now? The way this hooks on is, this is a tightening bolt, okay? So you got to tighten this up first, and then you do the final tightening with this. So if you ever have to go under there, circulators, to untighten it, you're going to move this and loosen it, and then we're going to slide it back and forth, okay? And then this thing moves, okay? You can see it's got these little pins that fit into little holes, and so if I'm doing a total shoulder, I'll do it like that, and the reason why I do it like that is it just gives me more mobility to rotate the arm into the positions that we'll need. Okay? So, lay this down. So we got the patient on the table. Why do we get a patient on the table? Who's our volunteer?
These going on.
Just don't make any decisions.
I won't make any decisions. So, when we put the patient on the table, what I like to do, what I would do is that I would have the patient position themselves. The big deal here, where this device falls short is that sometimes we don't support their back. And that occurs if we don't move them up high enough. Okay? So I would always have the patient position themselves, okay? And I tell them, scoot up till you feel your back up as far as you can go. Okay? Good. And then I put where's our leg holder? Okay? And then I put that in. Okay? And so you say, do you feel comfortable there? It should feel like you're in a beach chair. Does your lower back feel like it's supported? Okay? I would do it when they're awake. Okay? And just intervene with anesthesia and say, look, this is how we're going to position this, how Dr. Joe wants to do it, and have the patient, while they're awake, tell you, oh yeah, my back feels supported. Now sometimes we'll need to, once they get asleep and we move them into the semi-sitting position, because we're usually starting a little bit more reclined than this, we might have to make an adjustment. But if you start too low, when we sit them up, they're going to be too low. Okay? And I know that some of you, and I think it's a good idea, have then put in the kidney rest, okay, on, let's say we're going to operate on Dee's right shoulder, put in the kidney rest on the non-op side, okay, all the way in, and then I like this little trick, is only putting this one in part of the way, so it kind of holds the arm out. So whoever discovered that, that's a really good idea, because we can always put that in later. Okay? What else? So, the headrest. The headrest needs to be, and she's got a ponytail on there, but the headrest needs to be on the occiput, okay? Not on the neck, not on the top, but on the occiput. And we want to, if you just lay back for me, okay, go ahead. We want to have her cervical spine in line with her thoracic and lumbar spine. I got a little forward here, okay? And when we finally sit her up, you know, we always do this thing, are they tilted to one side, okay? So for the most part, we want them straight, you know, cervical spine in line with the thoracic and lumbar spine. And when we look on them in the AP plane, we want them straight, right to left. Now, you know that I will change that. Like if I'm doing a clavicle fraction, I'll have them extended a little bit off to the operative side so that we can get in there, okay? And I think it's best to get them arranged in this position when they're in the supine position, and then when we set them up, okay, you'll know I'll have anesthesia undo all of these, okay, and then someone supports the head, we move them in the sitting position, okay, and then we readjust. Okay, any questions about that? So now we have the patient positioned. Let's put him in the semi-sitting position. So why doesn't somebody come here and kind of hold the head? So, and you got to do this as a team. So we undo all of these, and then anesthesia usually squeezes this, and we raise it up. Okay, and these are either, what is it, pneumatic, I guess it is. Okay, so that it helps you to raise them up, so you're not lifting the entire patient's weight. And then we all kind of team up, and we go, okay, how's that look? You know, how's that look? Right about there. Head's a little forward, so I'll move it back. Is it down too far? No, it's right. This should be kind of at the bottom of the occiput, okay? I'll just say that that looks good. And of course, then we're going to put the face mask on. You know how those face masks fit. Okay? It's supposed to go band across the forehead, band across the chin, opening centered, okay? Like this. Okay? And that's it. Straps, it's always good if you're going to put this on, you just undo the straps before you put it on the patient. So now we have the patient positioned. We're going to put our kidney rest in, and we're going to prep. When we start the prep, you see I put this arm right here, okay? If we don't do that, if we leave it down like this, we're kind of below that waistline level where we don't want to be because it's not sterile. And so now when we go put the sleeve on, you know, it's really not, you know, sterile technique. So I always put it right about here. Okay? Draw this part forward. Usually this part, we want the elbow in so that we can get this over as far as we can. Okay? It's the opposite way that we, okay?
Makes sense.
Yeah. So that way we can get that in, gives us the most degrees of freedom. And that's a subtle point. I know Charlotte makes a big deal of that, but and so we want it up here. This seems to be away from where we're gonna, the person who's gonna prep, okay? And it's not in a way for us to drape. Okay. So I think that takes care of the tented beach chair and the spider arm holder, right? Any other questions about that? No. Okay. This slide right here. This slide gives you back support. So if I'm going to do a total shoulder replacement, I don't need to access the back of the shoulder. So we can slide this over a little bit more so it supports that scapula. If I'm doing an arthroscopy, I'm going to slide this over so I have better exposure of the back of her shoulder. Okay? And we can adjust this once the patient's on the table. Okay? But for the most part, if you know what the case is going to be, when we get the patient on there, you can check this. Okay?
Is that radiolucent, that top one? Like,
Yeah.
Okay.
This is all radiolucent except for the screws. Okay? This part isn't radiolucent. Okay? So, we've got the patient prepped, draped, or positioned, prepped, and draped. So let's operate. Let's do an arthroscopic rotator cuff repair. Okay? Oh, we didn't talk about drapes. To avoid confusion, I think the best thing to do is that if I'm going to do a arthroscopic case, we use that arthroscopic drape and won't put the bag on it. Okay? If I'm going to do anything else, okay, I like the two split drapes. Okay, so we got two sticky U-drapes, plastic, and then we have two U-drapes that are paper. Okay, and then finish off the legs however we need to. It's just that the arthroscopy drape tends to crowd the shoulder for an open procedure. And then if that thing starts sneaking in, you know, on a 2-hour total shoulder, you know, it's just not good sterile technique because it's kind of creeping onto our field. Okay? And especially for cases like clavicles, you just can't get enough exposure. Okay? So to make it simple, if we're doing a scope, we use the shoulder arthroscopy drape. If not, we're going to use the two U-drapes. Does that sound reasonable? You guys that have helped me on shoulders, I think that's where we've come to. Okay? So now we do have a patient prepped and draped. Do we have, oh yeah, we have some of our cannulas. So when I scope a shoulder, we're going to use basically 4 different arthroscopic portals, okay? In 2 of those portals, we're going to put plastic cannula because we're going to keep going in and out, okay, of those portals. So we're going to put a portal right in the direct back, right in the direct front, and then we're going to be offset in the back, offset in the front. Okay, those are the 4 basic portals that I will always use. There's some additional ones. Okay, so when we scope the patient, the first thing I'm going to do is I'm going to put the arthroscope in the back of the shoulder. The way that I do that is I like to use this little cannula to get in because it's kind of dull. Okay, so I don't scuff anything up, and it's a little bit smaller than the cannula that the scope goes in, plus the scope cannula has these fenestrations for the fluid, and that tends to catch on tissue. So I will actually create the portal with this. So that goes in. I'm in the shoulder joint. This comes out, and now I'm going to put the switching stick in. Okay, and take that out. Take that out for me. And then you're going to always hand me the scope cannula with the obturator out. And then we're going to put this one in over top. Okay? When we make portals, sometimes, especially if they're big portals, we want to kind of dilate them to get them to the bigger size. And that helps to do this. It's also safe so that we have less likelihood of scuffing up the articular surface of the shoulder joint. Okay? So now this is in the back of the shoulder, and that's our main viewing portal. And for many of the cases that we're going to do intra-articular work, I'll keep the shoulder in the back of the shoulder. Okay? How do we make the front portal? We're going to use what's called the Wissenger rod technique. And this is an example of a Wissenger rod. And this is from the old Dionic system that we got when I was first here 17 years ago. Okay? Now what we haven't gotten is a Wissenger rod, and we need to order. I don't know who's in charge of ordering, but I've told Tyson, and I think he's told somebody else, that we need a Wissenger rod that fits with these obturators. Okay? So this one doesn't fit. It's an old-fashioned Wissenger rod. Okay? This can actually be thrown away. It has absolutely no use. Okay? And here's another Wissenger rod from an old cannula system, okay, that I was using when I first got here. Okay? And we've used this before, but really it doesn't fit. It's a little bit too small, and it's been Gallagherized too. But that's how we're going to get the cannula. The portal in the front is that I'm going to take my arthroscopic sheath, and I'm going to guide it with the camera in it right up to the front capsule. Okay, so I know where the portal wants to come in on the inside of the shoulder. So I'm going to push this up there, take the scope out, and just use this for this purpose, and then I'm going to put this through, and you're going to see it comes out the front skin. Okay, and then we make an incision there. Now I have this sticking out that goes into the joint. I'm going to take one of these cannulas. These cannulas are all color-coded, okay? Gold and yellow match up. So when you take them out of the bag, you're going to put the cannula onto this thing, okay? And now it's sticking out of the front of the shoulder. With the cannula on it, we're going to slide this over, and we're going to march this into the joint, okay? Take this off. Now we have a cannula in. Take this out, put the scope in, and then fine-tune the cannula. Because they're threaded, we can just turn them. So now we have a cannula in the front of the shoulder. And that's how I always put the front portal in. Okay? And it's called the Wissenger rod technique. Andy Wissenger was one of my teachers back in Pittsburgh, and I joined his practice, and so I know Andy pretty well. He invented that.
Dr. DiGiovine, would you explain the no squirt on those cannulas? Because
What?
those are the ones you want are the no squirt. And I know we're getting the wrong ones.
Oh, yeah. Okay, so these are threaded. Okay, it helps to get them in, and it helps to keep them in. They make them in another way where they've got a little lip with a hook on it. Those don't work as well. Okay? And maybe some surgeons like them, but I don't. So when they got ordered wrong, and they weren't ordered with the threads on them, they were ordered with the little hook on the tip of it. Okay? So when you pick these off out of the box, make sure they're threaded. Right?
No squirt, right?
No squirt.
Threaded, no squirt, that's what they say on it. No squirt, because the other ones
No
didn't
squirt.
have that. And that's the difference, the fluid didn't leak out, is that correct?
Well, I think the no squirt is this little plastic cap that you have right here.
Okay.
Okay? And this plastic cap, I think can either be placed on the cannula. It must be able to be placed on the cannula. Okay? We never use it. It's a good idea because sometimes we do have it squirting around.
Right.
Okay? So, but that's what the no squirt means.
Okay.
The twist in is what you want. Okay? The other one is just a push in and it hooks the lip. Okay?
As far as the yellow or purple ones, do you want us to wait on that, or?
So let's say we know we're going to do a rotator cuff repair.
Okay.
Okay? Can almost be assured we use the purple. You could always just have that open. In fact, I think just about every arthroscopic case I'll use a purple.
Yeah.
Like a instability, like a Bankrupt repair, I'll still use a purple. So you can pretty much have this open.
Okay.
Okay? Load it on this thing.
Right, purple.
Okay? So now we got our front portal in. If we're going to do a rotator cuff repair, there may be some work we need to do inside the shoulder joint. Let's say we're going to do, let's say the patient also has a biceps tendon that's unstable, and we're going to do a biceps tenodesis. Okay? Then the sequence would be is I'm going to do that first before I repair the rotator cuff. And that may mean that I'm going to make another portal just to the side of that front portal. I call that the biceps portal. Okay? Those kind of portals I'll make with a spinal needle. Okay? Can we get a Mayo stand? Oh, we got a Mayo stand right here. I like to have a Mayo stand set up with the things that I use a lot so I can grab them without asking you for them. Okay? And the things that I like on here, I like the knife that I make the portals with, okay? The 11 blade, okay? I like this. This. We need a new probe. We ordered one when we got new equipment. It's either lost or it never came. Okay? This one I don't use a lot. I use it to kind of enlarge the biceps portal, so it doesn't really need to be on here. You always want to have the obturator on here in case it's changed. The other thing that will need to get made is that I had the company, we got an extra 1 or 2 of these, okay, and then we cut it off right here so we can plug it into the arthroscopy sheath so that it would still actually irrigate, it would circulate fluid. If you put this in and you have fluid running, it won't run. It fits too tight. So what I had him do was cut this thing off, and I call it the arthroscopic sheath plug. So if someone's making a list, we want to get like 2 of these, okay? And we can have our own machine people, you know, cut these things off, okay? And then we keep them up separate. And when I do that, well, if I have the scope in the back, but I want to look in the front, I've got another portal in, I can just take the scope right out, put this plug in, it'll still circulate the fluid, and then I'll go through one of my plastic cannula in the front, and I can real quick move the scope to different positions to see. Okay? So we'll put that on the list. So these things need to be here.
Were those, do you know where those ordered or they weren't ordered?
These were not ordered. These were not ordered. Okay? The other thing we need is, on every case I have 2 of these. Okay? And for that reason, let's say for instance, I have the scope in the back, okay, I want to look in the front, but I'm going to not just look real quick and come back again, I'm going to stay there for a long time. I'm going to take the scope out, put the plug in, and then I'm going to take another one of these sheaths, and I'm just going to put it on the scope, and I'm going to put it through the cannula. The reason why I'm going to do that is that this protects that scope. The most, expensive part of the whole, one of the most expensive parts of the whole system is this right here. Okay, now I will temporarily look without protecting this, but if I'm going to have that scope somewhere else for a long time, okay, I'm going to protect it with this. Okay, and that way I'm not going to break or bend that scope. Even a little tweak here, you'll break the fiber optics. Okay, you won't see anything on the outside of this, but if you just bend it a little bit, those little fiber optic bundles will break, and now you got a blurred spot on your screen. So we want 2 of these on each case. All right. The other thing that I like up here is I like one of those sharps things that has a little foam in it.
The count.
Okay, and I want you to put a spinal needle on that. Okay, and that needs to be up here, so that because many of my secondary portals, I will find it with a spinal needle, make the cut, put my switching stick in,
Tom, you want to grab one of those out?
grab another cannula and put it over top.
We'll just stick it on there so we have the whole thing seated.
Okay, so now we've got our basic portals in. I'm not sure what's not. Yeah,
The red one has the...
yeah, the ones that are kind of all foam, and you guys have them. We know you have them.
They come in
Yeah.
Okay.
And you want an 18 gauge, correct?
18 gauge. Okay. And sometimes I put it in with a little obturator in it. Sometimes I don't. Sometimes I'll use a spinal needle. If I got a lot of air in the joint and I can't get rid of it, I'll just stick the spinal needle through and I'll suck the bubbles out with the spinal needle. So now we got cannulas in. We're going to do some work now. Shavers, okay? I always use the Aggressive Plus. Okay? The Tomcat is really aggressive, and if you look at the picture, you can see that it has teeth on the outside sheath, teeth on the inside sheath. I find that's too aggressive, because if I have to do any shaving of articular cartilage, this just is too aggressive. So just on all my scopes, I just defaulted to using this. And these companies, Stryker among them, they make, dozens of these different things, and they want you to buy them all. Keep them. Look, I'm cheap. I'm going to use just a couple of things and make them work for everything. Okay? They're not that different. Sometimes we do need the Tomcat. If we got lots of tissue to debride, I might say open the Tomcat, and that'll make you open 2 of these. But for the most part, I'm going to try to open 1 of these per case. Okay? So the Aggressive Plus, and you can just open that. Okay? On a shoulder case, I'm going to use it. Okay? So that's our shaver. So let's fix a rotator cuff. Let's see. Other instruments that I want up here. There are 2 different types of grabbers. Let's see if there's actually 3. So 3 different types of grabbers. Okay? The tissue tensioner has these soft little wavy teeth. It's meant so that if you grab it, it doesn't destroy the tissue. Okay? And we got 2 of those up on this set. And then the grasper has these tiny little sharp teeth. Okay? And a pituitary, of course, is a pituitary. Okay? And so you want to make sure you have 1 of those up on each set. Okay? If you want to put 2 instruments up here, it'd be the grasper and the tissue tensioner. Okay? If I need the pituitary, I'll ask for it. You don't need to put, now, I'll tell you what, let's include in that this 1.5 upbiter. On a shoulder, if I'm going to use an upbiter, most likely it's going to be this. So these 3 instruments I would also maybe have up here. Okay? Suture devices. This is a suture grasper. You can see it's got this fine little thing. And do we have a